Now we'll move to the next session. Everyone got the paper. This is Osce session. The moderator will Dr. Sumanta Kumar Datto, faculties Dr. Soikot Samadda, Dr. Ratnadeep Ghosh, Dr. Tonaya Panja.
Good afternoon, everybody. We are almost at the end of the academic feast today. 2-day long program. At the end of the session, Osce, under the aegis of AOI, West Bengal branch. Our roadmap for Osce will be like this. Duration of session is 1.5 hours, dedicated 1.5 hours Osce session. Mock test will be for 40 minutes, 10 stations, each station comprising of 4 choices. 4 minutes for each station, so 40 minutes, 2 minutes extra time, I am explaining later. Next time this whole thing will be rerun to explain the answers by the faculties. With me I have my faculties, Dr. Tonaya Panja, may I request you to have your chair, Dr. Ratnadeep Ghosh from Haldia and Dr. Soikot Samadda from IPGMER. I welcome you all, and if any doubt is there, the student may have choice to ask us at the end of the session. It's approximately 8 minutes time, and if we can manage between the answer session, a few minutes extra may be available. So the instruction to the students will be, each station will be displayed in the monitor for 4 minutes with time phase out manner. It will be automatically off after 4 minutes of time, and you will get 10 seconds to settle down in between before going to next station. 10 marks per station. 10 marks per station. So altogether 100 marks, 40 minutes time. And I think the last request will not be kept. If the house permits, extra questions are there, we can discuss in between. So let us start from the beginning. You have your own answer sheet. You write it down within 4 minutes. Be ready for the next station. At the beginning, we the faculties and the moderator will not have any specific role to play other than changing the slide. You yourself answer it, and later on you yourself will check it when the faculties will discuss. Any doubt, any confusion so far? No. So we proceed to the next station. Station 1 for 4 minutes. Time দিয়ে দাও, ঠিক আছে, টাইমারটা চললো না কেন, নিজে চলো, ঠিক আছে। So this is the end of the mock test on Osce, and now it is time to submit the answer scripts for assessment. But instead of assessing, we will rerun the session again so that our learned faculties can explain the model answers. You accordingly check and rectify in your answer scripts. It was with the history of the patient. This will be explained by This will be explained by Dr. Tanaya on the history.
So, this is a patient of 33 years, female, who presented with a history of fall in a DJ night. That was the history. But if you look retrospectively, she had a history of vertigo lasting for hours in last 10 days with classical features of oral fullness, tinnitus, along with hearing loss. So this is nothing but Meniere's disease. But the next question was, what is the phenomena that she experienced last night? So, but there is a difference. You are right that this is Tullio's phenomena, but there is a difference that in Tumarkin's crisis, there also will be a history of fall. But the difference is that in Tumarkin crisis, there is no predisposing factor to the fall. But in Tullio's phenomena, there will be typical history of exposure to loud sound and fall. That differentiates these two, history of fall in case of Meniere's disease. So, if you go to the management of this patient, firstly, there is lifestyle modification. Like you have to ask the patient to take bed rest in case of acute phase. He or she has to take low salt diet and some salt restriction like that, avoidance of caffeine. And then in medical management, in acute phase, you can give Stemetil or diazepam to stabilize the patient. And for long-term support, you give acetazolamide as a diuretic that decreases the production of endolymph. And then you can give Stemetil MD or beta-histine like that. And for surgical management in long term, in severe cases, you can give intratympanic gentamicin. You can go for an endolymphatic decompression, or in very severe cases, labyrinthectomy or vestibular nerve section. Achha. The final question, 2 points that differentiates the history with BPPV. So the first thing is the duration of the vertigo. So in BPPV it will be only minutes or seconds, mostly seconds. And there will be typical change in head posture with the vertigo, the typical history. So that differentiates it from Meniere's. So I'll call up.
Thank you, Dr. Tanaya, for finishing in time. We shift to station number 2. No query now, please. It will be your session in the doubt clearing session. Maybe the time saved in between in our station or in the next session itself. Station 2 is on instrument. These were the questions. So this station will be discussed by Dr. Ratnadeep Ghosh in detail.
So here is we have a set of diagram in which a red lined instrument has been marked, and you have to mark the identifying the instrument. So it is basically a Trifon perforator with guard. If you closely see, it has a cutting bud of a very small diameter, maybe sub-millimeter, with a guard which is placed at a distance of 4 millimeter from the tip of the bud. It is used in the Varia technique for cochlear implantation, which is a transcanal procedure. Okay. So what exactly the procedure was being done? A tunnel made from the suprameatal well. Can you please go to the previous diagram, sir?
No.
Yes. So if you see, a suprameatal well is being created, and the tunnel is being made from the suprameatal well into the middle ear through the posterior canal wall, and this 4 millimeter distance helps to maintain the thin plate of bone in the posterior canal wall. Okay. Now the desired dimension, I have already said it is 4 millimeter, and regarding some intraoperative and postoperative complications of this procedure. So intraoperative complications, this may be damage to the facial nerve. We can encounter a CSF gusher. We can encounter a CSF gusher, or there can be problems with insertion of electrode in case of a ossified cochlea. And some postoperative complications, maybe flap necrosis, migration of the electrode, then wound infection, implant extrusion, implant malfunction. Now, another question which can be set in this background is, what are the advantages of this Varia technique over the conventional cortical mastoidectomy posterior tympanotomy route? Here, it is a less invasive procedure. It has a very short learning curve for the surgeons. It maintains the normal anatomy of the mastoid air cells, as cortical mastoidectomy is not being done, and wide visualization of the cochleostomy area as compared to the posterior tympanotomy, because we are raising the tympanomeatal flap and having a wide view of the round window niche area.
Okay, thank you, Dr. Ratnadeep. We shift to the next station, station number 3 on imaging. This will be discussed by Dr. Shoikat Samadra.
Good afternoon, everyone. Let's make it interactive 4-minute session. Firstly, how many of you do you think it is a computed tomographic scan? Raise your hands. All of you think it is a computed tomographic scan. Good. Second, it is a scan of temporal bone, right? Bone window, not soft tissue window. Signet ring, there is a signet. Signet is the vestibule. No, signet is not the lateral canal. Signet is the vestibule and the ring is the lateral canal. Diagnosis? Lateral semicircular canal. Which ear? Right ear. Very good. So it is a right lateral semicircular canal that has been indicated with the yellow arrow. Most probable diagnosis, obviously you can see there is a soft tissue, homogeneous density. You cannot comment on its radiolucency because it is a bone window and it is occupying the dome of the lateral canal, causing a fistula. So it is a case of right chronic otitis media, squamous disease with right lateral semicircular canal fistula. Fine? No problem with this? 2 relevant investigations. Already you have an investigation done. Radiology is already done. And the question says that the patient has complained of dizziness. So you need to evaluate dizziness, and the patient has hearing loss. So you need to evaluate hearing loss. So name 2 investigations. Pure tone audiometry. All of you accept? And vestibulometry. What vestibulometry you can do? Anything. But VNG with water, you do a caloric test, is it acceptable? So what will you use? Air caloric. Very good, very good. For your food for brain, what is the temperature used in air caloric? Go home and search it. Ke bollo? It's honor student. Very good. Surgical options available for treatment? Obviously mastoid exploration, but the answer should not end over here. Along with repair of the lateral canal fistula. Thank you so much.
Next we will shift to station 4. Will be discussed by again Dr. Tonaya.
So this is a 33-year-old patient who presented with a history of hearing loss. There is another history that she speaks in a very low tone and recalls that the problem starts during pregnancy. So this chart is definitely a pure tone audiogram of the right ear, and you can very well see that in the air conduction, the air conduction has been lowered and the bone conduction is in place, but there is a AB gap of more than 25 decibel, indicating that this is a conductive hearing loss, and there is a typical dip at 2 kHz. Okay, so this is definitely a Carhart's notch Now, why does this Carhar's notch occur? We know that in bone conduction there is a inertial component, one direct stimulation to cochlea and another is the ossiculotympanic pathway. But the resonance of the ossicular chain is maximum at 2 kHz. So that facilitates the transmission through the ossicular chain, and in any condition that will hamper this osseo-tympanic pathway will cause this Carhar's notch in the audiogram. So in this case, this is a case of otosclerosis because the patient has given the history of the hearing loss occurring in pregnancy like that. But any condition that can hamper this osseo-tympanic pathway, any kind of conductive loss can result in this Carhar's notch in Pierton audiometry. So this explains all these answers, that the hearing loss is conductive loss, finding is Carhar's notch, and the mechanism that I have explained. So the two probable diagnoses, one will be definitely otosclerosis and another will be any kind of ossicular chain ankylosis that may be some congenital or may be acquired. So that concludes this answer.
Thank you. Next we shift to station 5 on pharmacology. This will be dealt with by Dr. Ratnadeep.
Again, this lignocaine, we are using this drug in tons and tons of amount in our daily day-to-day work. So you need to know every nitty-gritty of this drug. So coming in first, the calculation of the dosage. In our practice for local anesthesia, infiltration anesthesia, we are using 2% lignocaine, either as such or combined with adrenaline. So the dosage will be 5 milligram per kilogram when it is plain and 7 milligram per kilogram when it is combined with 1:2 lakhs of adrenaline. Okay. Now then calculation of the maximum injectable dose. Here the body weight is given 70 kilogram, 2% lignocaine, that means 2 milligram per ml of solution, and with that calculation we can multiply the body weight of 70 kilo, which comes out to be approximately 24.5 ml. Now the mechanism of action. So what does lignocaine do? It blocks the sodium channels of the neuronal membranes and it prevents the achievement of action potential which is required for propagation of the neural stimuli. This action is desirable in our setting. What is the another use of lignocaine? It is class 1B anti-arrhythmic drug. The same blockage of the sodium channels in the heart is being used to prevent tachyarrhythmias or ventricular tachycardias. So, what happens if we inadvertently inject lignocaine into the blood vessels? We fail to push our plunger outside while infiltrating and straight away a large dose of lignocaine is administered into the blood vessels. So, as per the dose, two main toxicities are being observed. First is the CNS effects and then followed by, over a higher dose, the cardiovascular effects. In CNS, firstly it will be CNS excitation symptoms like nervousness, psychosis, irritability, paresthesia, tremors, followed by CNS depression leading to drowsiness, precipitation of convulsions, apnea, maybe death followed by. Then the few cardiovascular side effects that can be seen: bradycardia, hypotension leading to cardiac arrest. Okay. So then, so there lies another question, maybe friend, that what are absolute contraindications for using lignocaine? Or in what situations we will be very much watchful for using lignocaine? Maybe elderly patients who already have some heart block, bradycardia, unexplained hypotension, these situations we should be cautious. An absolute contraindication will be heart blocks, stroke Adams syndrome, Wolff-Parkinson-White syndrome, okay, sinoarterial blockage, which has not been corrected by pacemaker. If a pacemaker is there in an elderly patient, we can use lignocaine with caution. Okay. So there lies the importance of, and apart from that, other side effect or adverse drug reaction is local skin allergy. For that, each and every patient in which we are planning to infiltrate lignocaine has to undergo a skin sensitivity test with lignocaine. Any other things, Sumanta sir?
Thank you. Next, counseling. This cannot be a written down program. So somebody should volunteer and come. Here we have our real life scenario. One patient having, Dr. Shoikat is now patient, Tonaya supposedly his wife and 16-year-old boy. Somebody from the floor should come and counsel. I think you have written, but this cannot be a written program. So now you counsel. Ratandi, please. Record koro.
Please don't mind my Bengali. Okay. ठीक है. तो आपके पेशेंट को अभी सांस लेने में बहुत दिक्कत हो रही है. आप इस सिचुएशन की गंभीरता को देख सकते हैं. इसको देखते हुए आपको समझ में आ रहा होगा कि इनकी हालत ठीक नहीं है. इस वक्त हमें जो प्रोसीजर करना है वो एक लाइफ सेविंग प्रोसीजर है. अगर हमने ये नहीं किया तो इनकी मृत्यु 100% होनी है. आपके फादर नहीं बच पाएंगे. आप नहीं, सॉरी, यू आर 16 ईयर्स ओल्ड. आपके हस्बैंड नहीं बच पाएंगे. सो इन दैट केस हमें ये प्रोसीजर करना ही पड़ेगा. और अगर आप ये प्रोसीजर नहीं करना चाहते हैं तो फिर हमारे पास इस वक्त उनकी जान बचाने के अलावा और कोई उपाय नहीं है. तो क्या आप, देखिए, खतरे रहेंगे. खतरे तो हैं. किसी भी प्रोसीजर करने के समय पे हमारे पास कुछ ना कुछ खतरे ज़रूर रहेंगे. इस केस में इनके अगर हम इन पेशेंट को अभी हम ओटी टेबल पे ले जाते हैं तो हो सकता है शिफ्ट करने के दौरान ही इनकी मृत्यु हो जाए. ओटी टेबल पे नहीं किया जा सकता है. बिल्कुल भी नहीं. अगर इस वक्त दवाई से ठीक करा जा सकता तो हम ऑलरेडी कर चुके होते या हम वो करना शुरू कर चुके होते. अगर अभी इस वक्त हम ये प्रोसीजर नहीं करेंगे तो 100% इनकी मौत हो जाएगी. लेकिन इस प्रोसीजर को करने के समय में भी रिस्क रहेगा. ये बहुत मॉर्बिड प्रोसीजर. देखिए, इसकी हम गारंटी नहीं दे सकते. हम अपनी तरफ से हम अपना पूरा 100% देंगे, बाकी ऊपर वाले के हाथ में. और देखिए, ये बस अभी फ़िलहाल के लिए इमरजेंसी प्रोसीजर है. आपकी पुरानी रिपोर्ट्स के हिसाब से आपके पेशेंट के गले में ट्यूमर है जिसका इलाज हम सिर्फ इस प्रोसीजर से नहीं करेंगे. इसके बाद भी हमें आगे की चिकित्सा करनी पड़ेगी जिसके अंतर्गत हम इनकी एक बायोप्सी लेंगे और वो मांस का टुकड़ा आप जा कर के पैथोलॉजी में जमा करेंगे. जिसके बाद जो रिपोर्ट आएगी उस पर आगे की चिकित्सा. ये क्या कभी बोल नहीं पाएंगे और खाना भी नहीं खा पाएंगे? देखिए, वो आपके ऊपर डिपेंड करता है. जब एक बार बायोप्सी की रिपोर्ट आएगी हम आपके सामने ऑप्शंस रखेंगे. आपके पास सर्जरी का भी ऑप्शन रहेगा, आपके पास रेडियोथेरेपी का भी ऑप्शन रहेगा. उनमें से आपको जिस ऑप्शन की तरफ जाना है वो आपके ऊपर है. अभी जो आप करने वाले हैं उसके बाद क्या वो बोल नहीं पाएंगे? कुछ दिनों के लिए नहीं बोल पाएंगे, लेकिन उसके बाद वो हम उनको सिखा देंगे कि किस तरीके से उनको बोलना है. वो हम ट्रेनिंग देंगे.
I want to have some comment from senior teachers too regarding the counseling. Subhrata, please. The counseling done by ma'am.
Counseling is done for the immediate tracheostomy first, but the tracheostomy has some complications.
Yes.
That should be explained also.
Yes.
And about the definitive management and the voice rehabilitation, you have to very much stress. You have to give stress.
Just go through Scott Brown, volume 1. There is a chapter which gives in details how to break bad news. Here you came to break bad news. What I found very good about your sitting position, you did not sit against the patient, you sat beside the patient family members. That is a very inviting position, number one. Number two, The protocol to break bad news is called spikes protocol. So first you have to do the setup. Setup you did. Then you have to, which you did not do, invite. What do you invite?
Now you can understand the importance of the last session. You have to take it to your heart regarding the spikes session, because this may be a very important OSCE. As you know, OSCE can be of your knowledge, OSCE can be of your skill, and OSCE can be of your attitude and communication. So all this, I know that you have not read it. The spikes protocol, the Kalamazoo consensus, all these things you have to go through. So SPIKES, all these setups, I have given you the, I think it is already there in your WhatsApp group. So please follow that one, and you will find in the
All those
slide number.
recommendations are not only for theoretical purpose. Apply those things in your
You are the only person
in
who
your
is speaking
skill
over it.
everywhere.
It should be
You should
interactive.
adopt it in your day-to-day practice also.
It is a knowledge that has to be delivered at last. And do you know about emergency laryngectomy?
Okay, let us shift to next station of DOAP, demonstration, observation, assistance and performance. Somebody from floor again should volunteer. Sir, you go to question number A, pick up the necessary instruments to prepare oral swab. The thing prepared will just come out. It will be a foreign body in the desired ear, maybe right, maybe left, maybe both, maybe yours, maybe mine, everybody. So this is not, let us concentrate. Please, Ratnadeep, please. So, what was wrong with him? 3 points. One is the tip of the instrument. Tip of the instrument should be the middle of the body, so that the tip is not exposed and going to hurt your extremity canal, number one. Number two, spread the cotton like this, the tip of the instrument is in the middle of the cotton, and rotate the lower part, the down part, the inferior part, so that the upper part is puffy, and do not do this which will make you Johnson birds and put like this and sleep. No. And now you see, this will not come out easily. It will not be a foreign body. Again, it should not be stuck to the instrument too tightly. What are the reasons of incapability to remove the cotton? তো এটা তৈরি করা এবং খোলা, তৈরি করাটা দেখিয়েছি, মাঝে ইন্টারাপশন হলো আমি খুলে দিচ্ছি এবং ডাউন, এটা উল্টো করলেই খুলে যাবে উইদাউট মেকিং ইট ফরেন বডি। থ্যাংক ইউ, থ্যাংক ইউ, শেষ। Next is osteology. Osteology will dealt with Dr. Soikat. Be fast.
The osteology, this part, it is very important. Don't forget this diagram. Don't forget this part. It will come in front of you throughout your life. Number A is styloid process. Very good. You know the ligaments and muscles: stylohyoid, stylopharyngeus, styloglossus, stylomandibular ligament, stylohyoid ligament. You know the structures. Level B is mastoid tip. The mastoid tip gives attachment to the sternocleidomastoid, the posterior belly. Don't forget to mention the posterior belly. আর যদি আরো ভালো বলতে চাস, here it was given only two, the erector spinae group of muscles, splenius capitis, longissimus capitis. Structure C is very good. You know what comes out through foramen magnum. Brain structure, what? Spinal cord. If spinal cord has to come out, it has to carry the meninges along with it. A meninges has to have the CSF with. The vertebral artery has to enter. The spinal cord has to be supplied by the anterior and posterior division of the spinal arteries. আর একটা আমাদের accessory spinal. Very good. Structure labeled D. A male structure comes out through it.
Now going, so quickly, few telltale words in the question. Swimmer, mass in the nostril which bleeds to touch. Okay. Rhinosporidiosis, of course it is diagnosis. Now, so regarding the histopathology, what do we see? We see a chronic inflammatory infiltrate in the submucosa, and we can see structures of variable size with, endospores inside it. So this has less number of endospores. This can be a sporangium which is maturing into a more sporangium with more dense number of endospores, and subsequently it is lined by a thick chitinous wall. This is again a sporangium which is ready to explode and release the endospores again. So this can be a juvenile so this can be a juvenile sporangia, this a mature sporangia, and a mature sporangia which is releasing endospores. Now quickly regarding the pathophysiology of the disease, it has been a protozoal disease which has thought to be a fungus before, but still the debate is continuing where to classify it. In swimmers, it enters into the nasal mucosa or any other mucosa like the urethral mucosa. The endospores enter through abraded areas or areas of trauma inside the nose. Chronic inflammation sets in and leading to formation of a granuloma with submucosal angiogenesis, which gives rise to a bleeding polypoidal lesion, and subsequently as the sporangia matures, it can be seen as white dots over the mass. And treatment, of course, surgical excision. Points to remember is liberal cauterization of the base along with removal of adjoining mucosa. It mainly arises from the lateral wall of the nose, maybe over the inferior turbinate, over the nasal septum, with cauterization of the base and removal of adjoining area cuff of normal mucosa, and medically maybe oral dapsone 100 milligram per day from 6 months to 1 year to prevent its recurrence. Okay, that's all.
So this is clearly a specimen of total laryngectomy, which is cut open, and this is the posterior aspect. So that is the right side, this is the left side. So this is the right side, this is the left side. So the full name of the surgery, total laryngectomy with partial pharyngectomy with right hemithyroidectomy with neopharynx reconstruction. Now the next question, what is the minimum T stage in a transglottic cancer? Transglottic means definitely there should be vocal cord fixation. So definitely transglottic CA will be at least a T3 laryngeal carcinoma. Next is identify this red arrow structure. This is nothing but the right thyroid lobe. Now the next question is justify the rationale behind this hemithyroidectomy. Now there is a whole lot of debate on whether you should go for a hemithyroidectomy or should not. The reasons in favor is that the thyroid has the potential to be invaded in every laryngeal CA due to the anatomical proximity as well as the chance of hematogenous and lymphatic spread. But there is if you attempt for the hemithyroidectomy, there is a chance that the patient might go in hypocalcemia or in hypothyroidism. And also there is in long term that there is no evidence that hemithyroidectomy improves the oncological clearance. But in now what we routinely do is in case of subglottic involvement, we do the hemithyroidectomy. If there is visible infiltration of the thyroid with the cancer, then we go for a total thyroidectomy. And if extralaryngeal spread, then depending on the surgeon whether to go for a hemi or a total. Acha. Now, what parameters should we address while preoperative preparation? So if you think that first you have to stage the disease, so you have to go for a CECT base of skull to root of neck to check for the spread in the larynx as well as in rest of the neck. To check the distant metastasis, go for either a HRCT thorax or a chest X-ray along with USG whole abdomen and a CT brain. Then check the residual lung function by doing a pulmonary function test. Then you have to check for the swallowing, the nutritional status of the patient, as well as last but not the least, check for the thyroid function and serum calcium, as you may need a hemithyroidectomy in this patient. And the last question, you all know what are the options for voice rehabilitation. One is electrolarynx, and then is esophageal speech, and last is Provox, means tracheoesophageal voice prosthesis. Thank you, sir.
Any specific doubt that time you were asking? Anything, any station? Which station, you tell?
in differentiating Meniere's disease from BBVV, why can't hearing loss be an option for differentiation?
Hearing loss, maybe, yes, definitely. You can add to the point. Yes, definitely. In Meniere's there will be hearing loss, but in BBV,
but in BBV there will be no hearing loss.
Thank you for the addition.
Thank you. So you have already seen in the group, we have given all the presentation, all the study materials, and any doubt you can ask in the group, because all the teachers also in the group. So any doubt over the questions or anything you can ask.
Just wait for 1 minute.
1 minute, just.
So this is the end of the 2 days orientation programs. I think you are will get helpful to you, and though we have not covered all the points, but usually during examinations, not so very hard questions is asked. Usually the basic and easy questions are asked most of the times. Very rarely some difficult question is asked. So we are very thankful to all the faculties who have come and giving the lectures, and also we have noticed that some senior teachers, even my teacher, Dr. BKRC has also come to inspire us. It's a very great inspiration to us. So I think, sir.
I thank all of you, all the PGTs, those who have come over here. And it is a nice thing that to arrange this type of, yeah. So now it is, as you know, West Bengal branch started this program in the very beginning, a few years back, I think 5, 6 years back, isn't it? So now it has become a national program. So it is very happy to say that we are proud of it, that now India is following the West Bengal scheme, and it's a very good scheme. Now, before I finish, I think I want to ask one question to all of you, which is my very favorite subject, and all of you know, that what is the reverse neostepidotomy? Forget about neo, reverse stepidotomy. That might be a question to you during your practical exam. What is reverse stepidotomy? Anybody have got any idea? Do you have seen stepidotomy, isn't it? So what is reverse stepidotomy? This is actually reverse stepidotomy, was described by Hugo Fish in the year 1980. Now it is a very popular subject for otosclerosis surgery, and reverse stepidotomy has got many advantages, and it can be done almost in all the cases, but in some cases it is not possible to do, especially what Hugo Fish says in case of white sclerosis. Do you know what are the different types of sclerosis?
Sir, anterior foci.
Two types. No. Two types. According to Hugo Fish, it is not my. Two types are blue and white. Blue is the early otosclerosis, white is advanced sclerosis. So on that basis, what Hugo Fish says, if it is blue otosclerosis, it is very simple to go for the reverse stepidotomy. But in cases of white sclerosis, it is difficult due to subluxation of the incus, subluxation of the footplate of stapes and all those. But again, in the next article, he described that you can go for modified reverse stepidotomy. Do you know any idea about that? Modified reverse? So you have completed 2 days having a long discussion. Was there any discussion about this subject? Otosclerosis?
Sir, actually, otosclerosis is not in our discussion anywhere.
Oh, I see. Why not? It is not asked in the exam.
Actually, the PG class, orientation class, there is a most of the squamosal disease. There, this is only the practical oriented class is there. Thank you.
Thank you, sir.
Thank
for
you.
such important points.
So please come this side. We will take one group photo, and then everyone please take the your CME credit hour certificate. Hope this PG orientation class will help your exam, and all the best for the exam.